Hello, and welcome to my presentation of asthma in 12 to 18-year-olds. In the next several slides, I will review the asthma diagnosis as it is correlated with the other systems in the body. In addition, I will present many modifiable and non-modifiable factors related to asthma. Throughout these slides, you will see the thread of adolescence woven throughout and also the cultural impact of an asthma diagnosis on the most commonly affected population, African American boys of low socioeconomic status. Lastly, I present a treatment plan and some very important nursing interventions. So let's get started. All right, starting in cardiovascular and hematopoietic function, the way cardiovascular and hematopoietic function is related to asthma is simply that oxygenated blood is vital for maintenance of life, clearly. Any impact on lung function, which ultimately oxygenates the blood for the heart to pump out, will greatly affect the rest of the body systems, as you will see throughout the rest of my presentation. Looking at severe asthmatics, research has shown correlation between changes of lung volume and pleural pressures, which are both non-modifiable outcomes in asthmatics. Other non-modifiable cardiovascular changes in asthmatics include progressively increasing lung volumes, which will stretch pulmonary vessels, leading to increased pulmonary vascular resistance and right ventricular afterload. If hypoxia and acidosis set in, pulmonary vasoconstriction becomes evident, further contributing to increased right ventricular afterload. Left ventricular afterload is also increased due to high negative pulmonary pressures. Also, decreased cardiac output and decreased systolic blood pressure during spontaneous inspiration is seen. Overall negative intrapleural pressure drives transcapillary fluid edema into the alveolar space. Additional non-modifiable factors include heart rate variability, which is the result of the use of beta-2 agonists for asthma care, such as albuterol. Research shows these bronchodilators affect cardiovascular autonomic regulation. Essentially, the more albuterol administered during an acute asthma attack, the higher the heart rate will go due to the effect on the autonomic nervous system. Studies have shown that administration of beta-2 agonists in either high dose or in combination, such as Atrovent, resulted in domination of the sympathetic nervous system, potentially aggravating cardiac electrical instability, which would be especially concerning for those at high risk for arrhythmias. I'm thinking about our kids or teens with underlying heart conditions who you also have asthma. Studies have found dendritic cells, monocytes, macrophages, and lymphocytes interacting in such a way to either induce, amplify, or modulate bronchial inflammation. Recently, evidence has shown recruitment of regulatory T cells and suppression of inflammation. Those are both additional factors in the non-modifiable factors of asthma. In contrast, a modifiable factor is the risk of obesity in the adolescent asthmatic population. Very important piece of information that must be reviewed. As a result of obesity in asthmatics, heart and its vessels are at a higher risk for damage and disease. Studies have shown youth with a diagnosis of asthma often quit sports or even underperform in athletics, further contributing to this risk for obesity. And this is a modifiable outcome. Teens can certainly be in control of their weight and of their activity level. It's important, as you will see in towards the end of my presentation, that education is really key in making this a modifiable factor. Okay, moving on to respiratory function, extremely important area of the asthma diagnosis. Approximately 22 million people are diagnosed with asthma. Of this 22 million, approximately 6 million are children, and the term children is used loosely. It is used, it is considered up until 18, so it does carry those adolescents, the population that I am focusing on. Further demographics show that of this pediatric population, more boys than girls carry this diagnosis, while in adults, more women than men have an asthma diagnosis. One thought is that estrogen potentially leads to bronchoprotection in asthma. This is a topic we'll explore a bit further in the endocrine slide. For the pediatric population, extrinsic asthma is the culprit. Extrinsic asthma is a result of increased IgE synthesis and airway inflammation, leading to destruction of mast cells and release of inflammatory mediators. Manifestation of symptoms happens as a result of an environmental trigger, such as food, pollen, dust, mold, smoke, cockroaches, the list goes on and on. During an asthma attack, there is general airway inflammation, thought to be a major contributor to the symptoms, often seen during exacerbation, like shortness of breath, wheezing, bronchospasm. In addition to airway inflammation and bronchospasm, bronchial edema, bronchoconstriction, and mucus production are also hallmark indicators. You can see in the image I have on this slide what it might be like to breathe through an inflamed bronchus, such as an asthmatic might have during an attack. The normal bronchus is open, easy air exchange, whereas the asthmatic is like breathing through a straw. It's extremely inflamed. And then on the other image, bronchoconstriction, you can see the bronchial, how tight it is and how tight the smooth muscle makes it, and also the alveoli so trapped with air, just from all that constriction. You can see how it would be quite difficult to take a deep breath. Coughing is often the first symptom of bronchospasm, occurring in stage 1 of an acute asthma attack. Within about 15 to 30 minutes, inflammatory mediators are taking over, such as leukotrienes, histamine, and some interleukins. Approximately 6 hours after symptom onset, stage 2 begins and is a result of airway edema and mucus production. Airways progressively narrow due to bronchospasming, contraction of smooth muscle, inflammation from mediators, and mucus production. Air trapping, as we see in the picture, is also seen due to alveolar hyperinflation and the constriction of the smooth muscle. These symptoms are modifiable with beta-2 agonist use, so your albuterol symptoms with appropriate dose should be relieved immediately. Your symptoms of environmental triggers, those are generally kept at bay with a daily histamine dose. Those are not mediated by a beta-2 agonist. Okay, moving on to fluids and electrolytes and urinary function. The respiratory system is extremely important in maintaining homeostasis. It manages its deviations by excreting carbon dioxide, which is an acid. If respirations increase, so for example, if you're hyperventilating, more carbon dioxide will be blown off, thereby decreasing acidity. If respirations decrease or slow down, which could be an emergency situation, such as coding, less carbon dioxide will be blown off and acidity will increase in the body. Both of these are only modifiable based on your respirations. This chain of events will occur if your respirations increase or if they decrease. Amazingly, lungs only remove acids from carbon dioxide through carbonic acid. Any quick responses to restore homeostasis in this way are only for a short period of time, really only approximately 12 to 24 hours. Changes in breathing pattern can occur as well for a limited time prior to feeling fatigued. Specifically, in acid-base balance, respiratory acidosis, which is a small picture seen on the bottom right-hand corner, can result during an asthma attack. Frequently during an asthma attack, carbonic acid is increased relative to carbon dioxide retention from hypoventilation and decreased gas exchange. Correction for respiratory acidosis includes bronchodilators, oxygen repositioning, and possibly mechanical ventilation for severe cases. It's important to note that respiratory acidosis is the more common imbalance in those that are critically ill. So your extremely severe asthma attack, possibly on the brink of intubation, or again on the brink of coding. Alternatively, respiratory alkalosis, which I've also included an image for in the upper left, can result from hypoxia. It appears to be the main acid-base disorder in patients with less severe asthma. So your less severe, maybe your mild to moderate asthmatics, they might experience respiratory alkalosis. Looking at dehydration, poor fluid intake is not uncommon in any illness, certainly not one that's amplified with asthma. Dehydration is a risk. It could further aggravate a possible metabolic acidosis that could be going on from lactic acid accumulation and anaerobic muscle use. Looking at reproductive and endocrine function as it relates to asthma, to date, most asthma research has been done on eosinophil response and its contribution to bronchoconstriction. However, recently, studies, specifically one particular study, has been done on the role of epinephrine as secreted by the adrenal glands. Epinephrine is a potent vasodilator and may not have the presence in asthmatic airways as it does in those not experiencing an asthma attack. Research dating back to 1985 has provided evidence that during an acute asthma attack, severe asthmatics fail to raise plasma levels of epinephrine. Additional studies have shown correlation between obesity and asthma as related to insulin resistance, a complication where insulin is overexpressed, a common finding in children and adolescents with asthma. There is an adverse relationship between insulin secretion and airway contractility. Insulin resistance is a potential risk factor for asthmatics. Supplementation of insulin has shown to cause a mild decrease in pulmonary function. Studies in rats have shown insulin increases the capacity of airway smooth muscle to generate force in response to spasmogens. Insulin can also affect airway smooth muscle by altering glucose concentration. This is an important correlation because of the role of glucose increasing the contractile capacity of airway smooth muscle. The role of estrogen in asthma is a growing area of study, as I spoke about previously. Researchers have been looking into the bronchoprotective effects of estrogen in asthmatics. Estrogen therapy can provide benefit in decreasing airway responsiveness. The goal of this type of therapy is used to improve quality of life for asthmatics by individually tailoring hormonal-based therapies. Looking at gastrointestinal function, gastric peptides have been shown to play a role in airway narrowing, specifically guanylin, uroguanylin, and gastrin-releasing peptide. Uroguanylin and guanylin are two hormones produced in the intestinal mucosa in response to blood sodium concentration. Research has correlated levels found in the blood and urine with vascular permeability of the airways, commonly seen in inflammation. Evidently, the mRNA for uroguanylin receptor, the guanylyl cyclase C receptor, was the ultimate link in looking at these hormones and their relation to airway narrowing. Studies have shown that uroguanylin will inhibit airway resistance as shown in allergen and leukotriene challenges. In the case of gastrin-releasing peptide, studies have shown that this neuropeptide, normally stimulating release of gastrin, will prevent hyperresponsiveness induced by allergen exposure if blocked. The musculoskeletal function and its relation to asthma is more closely tied to the use of corticosteroids, which are very common in treatment of asthma. The influence of asthma for this illness system is generally held there. So if the 12 to 18-year-old patient does have persistent asthma, more than likely corticosteroids will be added to their long-term management plan, and this is not necessarily modifiable. These steroids are necessary. The benefit, as seen at the bottom line, certainly outweighs the risk of having open airways. Studies have found that long-term use of corticosteroids do have led to a lower adult height by approximately 1/2 inch. Growth was delayed mainly the first 2 years of initiation of therapy, but resumed normal growing speed after those 2 years among study participants prior to puberty. In one specific study, it is important to note that this study did not show that the participants made up for their growth. It's just that they resumed normal growing speed. Despite the growth retardation, the benefit of asthma control with corticosteroids continues to far outweigh the risk. It is a first-line maintenance treatment in persistent asthma. One of the many ways neural function plays a role in asthmatics is through the peripheral sensory neurons found within the airways. These specific receptors, such as TRPA1, become activated once a noxious chemical, such as cigarette smoke or certain scents, are inhaled. So essentially, once the environmental triggers are inhaled. Studies have shown correlation between immunogenic and neurogenic mechanisms in airway inflammation. Neuronal activation relative to airway hyperresponsiveness plays a role in mucus secretion, reflex response, irritation, and neurogenic inflammation. The specific study that I read looked at TRPA1 in mice. TRPA1 is an irritant sensing ion channel seen in airway chemosensory nerves. When looking at this research outside of immunity response, evidence showed additional links between immune and nervous system interactions within the airways, specifically at the exacerbation of asthmatic inflammation from the release of TRPA1. This is an important discovery because it could help target a more specified pharmacological treatment, such as TRPA1 antagonists in asthmatics, other than those of immune-directed therapies. Looking at integumentary and body defense functions, atopic eczema, a picture is shown here, is a chronic inflammatory skin condition characterized by intense pruritus worsening at night. It is extremely common and correlated with asthma. This type of eczema is often seen in periods of remission and exacerbation resulting from decreased immunity defense. Skin becomes sensitive from frequent scratching and often is discolored from the constant irritation. Unfortunately, bacterial skin infections can occur as a result of skin bacteria entering the irritated opened site. Common sites for adolescents include knees and elbows. Similar to asthma, eczema can worsen in cold, dry air during upper respiratory infections, dry skin, emotional stress, and environmental allergens. The correlation between asthma and atopic eczema has caused significant amounts of research. There's documented association between eczema and asthma, specifically between that of severe eczema and increased production of IgE. A correlation between early eczema and development of asthma has shown that those with eczema early on do have an increased risk of developing asthma. In asthmatics, this inflammatory response is often triggered by environmental allergens such as cold air. Research focuses on IgE commonly found in mucous membranes and the skin. Looking through the lens of airway hypersensitivity, asthma would fall under the type 1 hypersensitivity category. Exposure causes T cells to activate and bind to mast cells. Subsequent exposure in large doses is necessary to cause this response. Once enough IgE is produced, the person is then considered sensitized. Repeated exposure then causes the antigen to combine with IgE, releasing cytokines, prostaglandins, and histamines. The end result is evidenced by inflammation and pruritus. As I stated before, I would be looking in the cultural and gender implications of asthma and its prevalence among African American boys, which research has shown has been increased. While some studies suggest that influence is larger ethnically, others have shown that socioeconomic status is actually the larger influencing factor. What we do see is exposure to allergens like tobacco, smoke, pet dander, mold, cockroaches, etc., are all common in housing complexes where it is often that minority population will live in, setting up those particular adolescents for increased exposure to environmental risk factors. For some populations, these might be considered modifiable factors. It can just move. But for many, especially those of low socioeconomic status, minority population, these are non-modifiable. These populations definitely will have multiple competing priorities, and often this does not win out. Due to the high rate of exposure to indoor allergens, it is difficult for this urban asthmatic adolescent to successfully reduce these symptoms over a long-term basis. Many studies have shown that minority children demonstrate underuse of preventative therapy and lack of compliance and follow-up care after acute exacerbation, resulting in emergency room visit or even hospital admission. Additionally, findings show that lack of adherence to medication regimen has, again, multiple contributing factors. Adolescents with asthma from mild to severe, so the whole gamut, generally present with more affected distal airways and an increase in distal lung resistance. Although that is neither cultural nor gender related, it is adolescent specific. Additionally, adolescent boys tend to have more hyperinflation with an increase in residual volume as well as total lung capacity when compared with girls. Of interest in this population is the higher rate of extrinsic asthma consistent with higher serum IgE and eosinophil levels. Unlike environmental factors, which given the appropriate circumstances, can be modified, the anatomical and physiological changes due to asthma in the airways is irreversible despite strict control and adherence to asthma management. It can be treated and controlled with appropriate pharmacological intervention and education. This next slide is a concept map illustrating asthma in the adolescent as explained through both modifiable and non-modifiable pathophysiological factors, specifically as related to minorities. Additionally, this concept map addresses behavioral response of minorities to said modifiable and non-modifiable pathophysiological factors. Modifiable factors for asthmatic adolescents include symptom control, quick management, adherence to treatment plan, education, general health, and allergen avoidance. Culturally speaking, it is important for the minority adolescent to be aware of allergen exposure, adhere to corticosteroid maintenance treatment, follow up with care post illness or exacerbation, and to follow asthma action plan. Adolescents, specifically minorities, should be encouraged to self manage their asthma, maintain activity, and avoid triggers. Non-modifiable factors for asthmatic adolescents are primarily anatomically based. These factors include effect on distal airways, increased distal lung resistance, increased hyperinflation in boys, and high rates of extrinsic asthma commonly seen in the school-age and adolescent asthmatic population. Additional factors include elevated IgE and eosinophil levels, persistent airway inflammation, and low pulmonary function. For some adolescents, an asthma diagnosis is not just moderate to severe, but instead is treatment resistant. For this population of asthmatics, more intense treatment and often higher doses of medication are required. Culturally speaking, the minority adolescent often receives substandard care, which may or may not be modifiable, as I spoke about in previous slides. They may or may not be able to modify the environment in which they live and go to school, and may have difficulty navigating language and literacy barriers. As in modifiable factors, education is equally as important to control the factors that can be controlled and have knowledge of those that cannot be. Technology is an extremely important part of culture in today's world, and it can simply be streamlined into medicine if given opportunity. For adolescents, the ultimate goal is to get them to comfortably manage their own asthma. So, one of the great ways to do this is to use something that teenagers love, mobile phones. A group of residents in Florida turned to mobile phones to help aid teenagers in self management. The physician's goal was to enhance pediatric adolescent patients' interactions with healthcare providers. They used downloaded apps as a way of providing new avenues for enhanced communication. This provided ways for physicians to provide appointment reminders and send them specific health messages related to a particular patient's knowledge of self-care. For example, if the patient was doing really well with their treatment, with their maintenance, they might get a good job. If they weren't doing so well, or it looked like and I will talk about an asthma action plan in the next slide, if they are approaching a yellow caution section of the asthma action plan, the provider might reinforce the need for them to come in and get checked out. Physicians felt additional benefits in increasing interaction and facilitating follow-up between appointments was especially beneficial. Additionally, this type of management helped patients to develop self-management skills and as a consultation channel. And all this type of communication can lead to improved outcomes in adolescent care and positive reinforcement to the patient. This allows the provider to reinforce appropriate decision making and eventually progressing toward self-management, specifically for those who are not quite there yet. Okay, so now that we've gone through all of the body systems, we've looked at all different areas of asthma and ways that things that technology, for example, would play a role in asthma treatment. Perhaps the most important part is now the treatment plan and nursing interventions. Given that acute exacerbation of asthma are overall non-modifiable. In other words, if an asthma attack is happening, it is going to happen and it will continue until a rescue medication is on board. The following interventions are ways in which asthma is managed by both nursing and medical staff. So, initially, or not only initially, but one of the biggest things is an asthma action plan, which I've included on this slide. I included the Massachusetts Asthma Action Plan, which is where I work, and I think it actually is the best one that I sort of briefed through while looking up asthma action plans. I do want to mention that this particular one is in English because I speak English and I read English. There are many languages that they come in, and they're easily accessible on the CDC website, but this particular one is in English. So, an asthma action plan is a step-by-step management plan to treat asthma symptoms. It is color-coded, as you can see, green, yellow, red, and it has been shown to decrease hospitalizations as well as decrease emergency department visits. It is extremely important for this plan to be reviewed until there are no longer questions, and in a way that both adolescents and their families will quickly recognize and manage symptoms for appropriate treatment. Frequently, we will give the asthma action plan to the adolescent and to mom, who's generally with them, and we'll tell them, one goes to school, one goes on the fridge, and then one goes somewhere else, in a locker, wherever, where it's easily seen. Therefore, you can always see, okay, you're doing well, continue with your controller. Maybe getting a little sick, let's bump up, slow down a little, let's add whatever, and then on to red for emergency intervention. Additional approaches to therapy include a stepwise approach, which allows the caregiver to assess for exacerbation versus control by looking at illness severity, treating it, and then reassessing control at frequent intervals. This allows the caregiver to escalate or step up therapy in periods of uncontrolled asthma, and then to step down therapy during well-controlled periods. Generally, caregivers look for severity over 3 months prior to initiating step-down therapy. Additionally, step-up therapy can be initiated over a short term, for example, exposure to dogs during a trip to a grandparent's house. Pharmacological interventions such as albuterol, as I spoke about previously, and corticosteroids are important in asthma management. I also mentioned the use of histamines. Beta-2 agonists, smooth muscle relaxers, are vital to rescue and quick relief during an acute asthma exacerbation. Inhaled corticosteroids are important in long-term asthma control for its anti-inflammatory effects. Overall, inhaled corticosteroids are considered superior, and despite musculoskeletal effects, they do remain the mainstay controller treatment for pediatric asthmatics. Perhaps the biggest thing of this entire presentation, if nothing else is taken away, is the need for education. This is the most important nursing intervention for adolescent asthmatics. Not only to the adolescent themselves, but to the family, to keep on target for achieving a healthy life. Substantial amounts of education and support must be given to the families and the patients. It's important to include what happens to the body during an asthma attack and what the patient must do in order to intervene, and to encourage them, to help them to understand that unless intervention happens, unless you take your inhaler, it will not stop. They must be taught the necessary responsibility of carrying a rescue inhaler with them at all times. It's extremely important to identify environmental triggers and to teach avoidance, if at all possible, to encourage independence with self-monitoring, and encourage as much self-management as they're able to manage. Recommendations to remain active are extremely important. I hope you've enjoyed this presentation on asthma, and I look forward to hearing any and all comments. Thank you.